Good day. My name is Michelle Levander. I'm the director of the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, How Can Healthcare Do Better for LGBTQ plus patients? The Biden administration recently announced new federal rules to protect LGBTQ patients from discrimination in healthcare. The move reinstates protections struck down by former President Donald Trump and expands on Obama-era protections. The policy reversal reflects the deep political divide in the country on gender-affirming care, with half of the states banning this care for minors. South Carolina, in fact, is poised to become the 25th state to ban gender-affirming care for minors. There's a bill awaiting signature on the governor's desk as we hold this webinar today. And some states have also implemented limits to access to transgender care for adults too. Against this backdrop, research shows that many LGBTQ plus patients report persistent discrimination in healthcare settings, as we'll hear from our speakers today. Such experiences can worsen stress for a group of patients who are already more likely to experience high rates of mental health crises, chronic disease, physical disabilities, and homelessness. Today, we'll discuss these recent policy developments. We'll hear about forward-thinking approaches to combating discrimination in healthcare settings, and we'll talk about how journalists can tell thoughtful stories on these disparities and policy swings. Joining us is Carrie Kandrian, an associate professor in the Division of General Internal Medicine at the University of Colorado School of Medicine. Her research examines how communication affects outcomes in healthcare, with a focus on older lesbian, gay, bisexual, transgender, and queer adults and those who care for them. Jen Christensen is a producer with CNN's Health, Medical, and Wellness Desk. In addition, she produces multi-platform projects and documentaries. She was also a 2020 fellow at the Center for Health Journalism. She's a past president of the Association of LGBTQ plus journalists and is currently on its board of directors. She has earned the highest honors in broadcasting, including the Peabody and the DuPont Awards. Lindsay Dawson is Associate Director of HIV Policy and Director of LGBTQ Health Policy at Kaiser Family Foundation. She focuses on LGBTQ health policy issues, particularly those related to disparities, access, and coverage. Her work also focuses on how health systems, insurance coverage, and federal funding shape access to care for people with HIV and the programs that serve them. This webinar is made possible thanks to the generous support of the Commonwealth Fund and the National Institute for Healthcare Management Foundation. We'll be archiving this conversation later today at centerforhealthjournalism.org. A word about our format: we'll be hearing from our speakers first, and then we'll turn it over to our audience for questions. Please feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel. You can also write us there if you're experiencing technical problems. Now let's get underway. Lindsay, why don't you start out by giving us a big picture view of how LGBTQ plus Americans are experiencing healthcare in this country, as well as the clashing policy developments that seek to expand or curtail their access to care.
Great, thank you so much. It's a pleasure to be with everyone. And as I load my slides, because many of you are journalists, I just want to share that I'm on the KFF policy side and not on the news side. And even though we practice this, my slides have gone missing, so bear with me. Here we go. Okay. So I'm going to begin by giving you sort of an overview of some of our findings from a recent survey that our polling team put in the field to explore the experience of discrimination and stigma that LGBT people experience broadly, but specifically we'll do a deep dive into health. And then I'll touch on two emerging policy areas that I think are particularly important to focus on as we think about health and how policy impacts access to health, healthcare, and well-being, or creates barriers. So like I said, this comes from our recent survey on racism and discrimination, and that looks at a range of issues, and we had a special focus in one brief on LGBT experiences with discrimination. So LGBT adults are more likely to say that they
And Lindsay, let
experience.
me interrupt you because your slides are not showing for some reason.
Oh no, I'm
Just
on my
like your
second.
index is showing, so you might
Oh
want
no,
to reshare.
I'm so glad you interrupted me.
Perfect.
There we go. Okay, so you didn't miss much. Intro, our new brief, and the slide that we're on. So LGBT adults are more likely than non-LGBT adults to report experiences of discrimination in their lives. And this could be discrimination based on any factor, but it's quite striking the sort of range in which these experiences are happening. And two that I'll highlight is that a third of LGBT adults say that they have been threatened or harassed at least a few times in the past year, compared to just 12% of non-LGBT adults. And a quarter say that they've received poorer services in restaurants or stores. And of all the experiences we asked about, 2/3 of LGBT adults compared to 40% of non-LGBT adults say that they've had these experiences. And LGBT women and younger LGBT adults are more likely to report discrimination. I'm going to shift into talking about some experiences with healthcare providers, but broadly, I think it is important to note that most of the time, LGBT adults say that they have pretty good experiences with their healthcare providers. So their providers are explaining things in a way that they can understand. They feel like their cultural values have been respected, that they're involved in their decision making, that most do think that there's enough time spent in a visit. But when we start asking about disrespect and being treated unfairly, we find that a third of LGBT adults say that they've been treated unfairly or with disrespect by a healthcare provider in the last 3 years, compared to just 15% of non-LGBT adults. And that this is a more common experience for younger LGBT adults and lower income LGBT adults. And this is important, not just because those are painful experiences in the moment, but because they have real world implications for health and healthcare access. So of those adults that said that they have had a negative experience in the past few years, 40% say that it means that they were less likely to seek care. Over a third say that it caused them to switch providers. And about a quarter say that their health actually got worse as a result. And in every case, that's quite significantly higher than the non-LGBT adults. And interestingly, even though those rates were fairly high, when we start asking with specificity, have you had these specific experiences, we see even higher rates that they've reporting that they've been having these negative experiences with healthcare providers. So 4 in 10 LGBT adults say that it had a provider assume something without asking. A third have had a provider blame them for a health problem. About a third have been ignored when they have a direct request or a question. About 1 in 5 have been refused a pain prescription that they believed they needed. And altogether, 6 in 10 LGBT adults say that this has happened to them. One of these things has happened to them, double the rate of non-LGBT adults. So perhaps not surprisingly, given these negative experiences, LGBT adults are taking steps to try and mitigate these challenges that they're facing in healthcare. Over half of LGBT adults said that at least some of the time during doctor's visits or provider visits, they feel they have to be careful about their appearance in order to be treated fairly. And over a third say that they prepare for possible insults with a doctor or a healthcare provider. Much higher than the share for non-LGBT adults, and 6 in 10 say that they've done one of those two things. And it's important to understand these experiences of discrimination because we know that stigma and discrimination can exacerbate mental health challenges. And indeed, we find that LGBT adults report that their emotional health or well-being is fair or poor. 40% say they have fair or poor emotional health, compared to 16% of non-LGBT adults. The shares are strikingly high among those who are younger and those who are of lower income. And LGBT adults also report more frequent experiences of loneliness, anxiety, and depression compared to their non-LGBT adult peers. So shifting now that we kind of have the backdrop of experiences into an evolving healthcare policy landscape, where we see that protections and prohibitions for LGBT people in healthcare are part of the policy environment. So I'll touch on one, the state law environment that's restricting youth access to gender affirming care, and Section 1557 of the ACA. We have a policy tracker at KFF that examines what states are doing in terms of youth access to gender affirming care. And in the tracker, we provide both information about the state policy itself, but also litigation that's occurring in this climate. And in fact, 17 of the 24 states have laws that are being challenged in court. And another thing we try to do with the policy tracker is show how broad and deep these policies are. So this map showed the proliferation of these states having enacted these policies over time, and it has happened quite quickly, particularly in the one-year period between January 23 and January 24, where we saw 20 states enact these laws. So I mentioned that they're broad and deep. This is on their face, the laws state that they are aimed at restricting or prohibiting minor access to gender affirming care. And when we say gender affirming care in these laws, it's typically puberty blockers, hormone treatment, and surgical care. But in addition to that prohibition, many, almost all, in fact, have provider penalties. These are professional penalties and criminal penalties, with 5 states that actually have felony penalties for providers. Many have aiding and abetting provisions. These are typically aimed at providers, but can sometimes be more general and make it so that it's difficult to make a referral for this care outside of the state. There are also provisions that impact parents, teachers, and counselors. So we're starting to talk about a whole support system of a young person that could be reached by these laws. Rights of action are defined in many of the states for minors, parents, and attorneys generals. So again, really kind of highlighting the risk to a provider in providing this care that is evidence-based and recommended for those for whom it's medically necessary. In addition, even though these laws on their face are about minors, many do have provisions that would impact adult access. So that could include in the Medicaid program by defining minors to include 18-year-olds, or having provisions that touch on private insurance. And finally, another notable area to highlight is that while these laws prohibit the use of these services for gender affirming care, every single law has in it an exception for use of these gender affirming care services for non-gender affirming care purposes. So for example, puberty blockers for somebody who's entering early puberty. Okay, so that's kind of about prohibitions. And now turning to protections. Section 1557 of the ACA holds the law's major non-discrimination protections, including those based on sex. And we saw new regulations from the Biden administration come out just this last month. And 1557 is a part of law that applies to any health program or activity that receives federal financial assistance. So this includes state Medicaid agencies, parts of Medicare, many health insurance plans, and most hospitals and providers, among others. And what's important for this discussion is that the interpretation of sex has changed across administrations and over time. And under the Biden rule, it is the most expansive. So it includes explicit protections on the basis of sexual orientation and gender identity, lays out specific protections for transgender people and access to transgender care. But it is important to watch this moving forward because litigation persists. These regulations have been challenged across every administration. That being said, protections have been found in the ACA itself, so regardless of what's happening in the regulations. Another area to watch here is how state laws that prohibit gender affirming care are going to interact with the 1557 regulation. And it's certainly something that it seems like HHS is aware of and monitoring based on the rule. And then finally, really considering how religious freedom protections and LGBTQ civil rights interact will also be important to watch in the 1557 space, but with LGBTQ rights more broadly, it's certainly something that the Bostock Court warned us about when the Supreme Court brought that decision down. So thank you very much. I'm looking forward to the rest of the presenters and to your questions. And as always, please feel free to reach out to us at KFF if any of this can be used to you or if we can help in any way. Thanks.
Harry, let's turn to you. Your research has taken an intimate look at how discrimination hits especially hard for older LGBTQ plus adults. Tell us about your findings, what can be done, and some promising models.
Great. Thank you, Michelle. Can you see him okay?
Yes, perfect.
Great. Thank you all for being here. And Lindsay, that was terrific. I'm Carrie Candrian. I use she, her pronouns. And I'm a researcher and an associate professor at the University of Colorado School of Medicine. A large part of my research focuses on older LGBTQ people, the disparities they face in healthcare, and especially at the end of life. As you can imagine, end of life is hard for everyone, but it's even harder for people who are older and LGBTQ. Why? There are three major reasons. First, financial. 1 out of 3 LGBT adults live at or below the poverty line. A third. Second, many people who are older and LGBT have a very thin network of support. They're less likely to be married, less likely to have kids, and they're more likely to be estranged from their biological family, which means less help with care, support, and advocacy, which, as we all know, are really important things when you're dealing with healthcare and especially end of life. Lastly, and really amplifying and underlying all of this, is a lifetime of stigma and discrimination, which, according to Harvard Medical Magazine, can take up to 12 years off their lives. Why 12 years? From the research we have, LGBT adults are disproportionately at risk for a variety of health outcomes. They have higher rates of anxiety and depression, substance abuse, cardiovascular disease, cancer, and suicide. How exactly does stigma and discrimination have such an impact? Let me give you some context. When I talk about older LGBT adults, I'm talking about people who grew up in the 40s and the 50s, like Shirley, who didn't come out until she was 81. When being LGBT was completely taboo, it was illegal in most states. People lost their jobs, their homes, their families, like Anne did. As you may know, up until 1973, the American Psychiatric Association listed homosexuality as a mental illness. It wasn't until 1990 that the World Health Organization removed their classification. Just imagine growing up thinking that there's something this wrong with you, that you were sick because you were LGBT, how vulnerable you would be, and how much you would internalize that stigma. And even though the laws have changed, the APA changed, the stigma has stayed, and it affects the way LGBT people move through the world. That's why many people who are older and LGBT have honed what I call this habit of silence around this core part of themselves. Silence is a critical defense strategy. It exists in all aspects of our lives, but importantly, in healthcare, it also exists. Almost half, like Lindsay talked about, 40% of LGBT adults say their own doctors and those who care for them don't know they're LGBT because they're afraid if they tell them, their care will get worse. And they're not crazy for worrying. 2021, 56% of LGBT adults report experiencing some form of discrimination from a healthcare provider. For those who are trans or gender diverse, it jumped to 70%. About 3 years ago, I interviewed this woman. Her name is Esther. When I met her, she'd recently lost her wife, Kathy, to cancer. The thing was, when hospital staff realized they were a couple, Kathy's care got worse. So they felt like they had to hide their relationship through Kathy's diagnosis, an illness, and treatment, and ultimately her death. When I asked Esther what the hardest part of the whole thing was, she said, "My wife was dying, and I couldn't even say we were married." Since they were hiding their relationship, Esther couldn't be in the room. She couldn't talk with the care team about next steps. She couldn't advocate for her wife on any level. She couldn't even hold her wife's hand. Then, when Kathy died, nothing. No one said a word to Esther. They had been together 33 years. What Esther's story reveals is that communication affected the outcomes of two people. Kathy didn't have the support or the advocacy she needed from the person she loved. because Esther was shut out as non-family. And Esther got nothing, no recognition, no grief support. She was just the good friend, the emergency contact, not a grieving spouse who just lost the love of her life. Unfortunately, Esther and Kathy's story is not unique. This is a choice LGBT patients face all the time. Do I come out and risk being treated badly, risk not having my person in the room? Or do I stay silent and hide a fundamental part of who I am? It's a heck of a choice. On the one hand, we have documented discrimination and disparities in outcomes. On the other, we have people who are understandably worried about sharing this information and who have honed this habit of silence. Compounding the problem is a healthcare system that doesn't routinely ask about sexual orientation and gender identity, or SOGI data for short. It's like an official don't ask, don't tell policy. We don't ask because it's currently not built into a lot of our routine intake forms, our questions, our get to know you interactions with patients. So it can feel uncomfortable for both the asker and the teller. If you think about it, in healthcare, we unintentionally limit how people share critical information. And that means we get incomplete data. Unfortunately, this will continue unless we make it really clear that it's safe to share and we start asking. So how can we improve healthcare for people who are LGBTQ? Legislation is one thing, giving protections to people that are long overdue is a critical step. But it's really hard to legislate the way people think and feel, particularly about the LGBTQ community. What we can do is change the way we communicate, the way we talk, and the way we listen. And one big way is what I call breaking the scripts. In healthcare, a lot of the way we interact is very scripted. The forms, intake calls, the hospice admission conversations, we don't think about it, but they tend to be very formulaic. Are you male or female? Are you single, married, divorced, widowed? Who's your emergency family contact? But we need to break these scripts and open them up in a way that gives people space to answer in a way that fits them and their lives, and take the burden off the patient so they don't have to be the ones to come out over and over to a battery of new people when they are sick, scared, and overwhelmed. The thing is, a lot of these tools in medicine, the way we get information about patients, are critical because at their best, they tell us who a patient is, what they want. The challenge is if you can't say these things, it's very hard to have these things. And these questions are often loaded with assumptions that aren't often spoken, but they're definitely heard. For example, when the question is asked, are you married? How do you answer if you're not officially married? Or if the form asks for family contact and you're estranged from a biological family? But when we ask these scripted questions, we don't even get the information we really need. What we're really trying to understand is the who. Who's the biggest support in your life? Who needs to be in the room when we talk about your care? Who's going to need support so they can support you? Who are your people? This is how scripts contribute to a habit of silence and how they can impact LGBT individuals positively and negatively when they're accessing healthcare. Just think how different the outcome could have been for Esther and Kathy if someone had asked the questions differently. And keep in mind that most of the data we are using in healthcare research is based on these scripted questions, which means there's a big group of people not being counted. We don't have complete and accurate data about the LGBTQ community because we don't consistently ask SOGI questions like we do other demographics. The result is, in the vast majority, or the majority of health literature and research, data is incomplete, which makes it hard to feel confident when we analyze the data and hard to make policy decisions that could actually improve outcomes for this community. And the thing is that because of the stigma and discrimination and habit of silence, a lot of people don't even realize that they know LGBT people, that they're caring for them, that they see them in their daily lives, and that the way they're interacting and communicating can keep these people silenced. 2 years ago, I was training 800 staff members in 6 faith-based assisted living communities in Colorado. The focus was inclusiveness for LGBTQ residents and staff. We had tremendous pushback from leadership. We couldn't say the words LGBT, we couldn't use a rainbow anywhere. Leadership wondered why the training was necessary since they didn't have these kinds of residents. A year later, they finally let me in. They gave me 45 minutes to go into each of the communities and tell them why this training and project mattered. So as a researcher, I did a total data dump, shared a lot of the statistics I've shared with you all, like the 12 years, or the fact that 75% of older LGBT people go back into the closet when they enter long-term care out of fear of discrimination. I got silence at the beginning, nothing from the audience. There was a total disconnect between the research I was talking about and the fact that this was actually impacting real people. Then I started to get comments like, why would anyone choose this lifestyle? Or if we allow someone who's gay, will they have HIV? I was pissed. How could these people not realize that I was talking about real people living in their communities? As I started to listen and calm down a little bit more, I realized that a lot of these people, staff and residents, truly believe they had never met someone who was LGBTQ or thought they had. So all they had were images and stories and stereotypes, things that created a lot of fear of the unknown. I drove home after one of those sessions and I thought, I just need to let people see LGBT people as real people they see in their everyday life. And that's one of the problems with data and statistics about the LGBTQ community. It's so easy to generalize when you're talking about big numbers, about groups of people you don't know or think you know. And it makes it easy to look away. It's much harder to make assumptions about a whole group of people when you know them as individuals and when you're looking at them in the eye. So out of this frustration, I created an exhibit called Eye to Eye. It's 30 photos of older LGBT people who have met my research. It's been on display in churches, medical centers, art galleries, and community centers. These pictures help humanize the data, which is a deep goal of mine as a researcher, to show the people behind the statistics. So when I talk about these devastating numbers that affect people who are LGBTQ, my hope is that the people listening will then be able to see real people that they can picture, and hopefully these numbers will then resonate and they'll understand and care, and hopefully help stop the fear before it leads to more hate. So I'd like to leave you with this thought. This habit of silence has existed for decades and still affects the way LGBT people, particularly older LGBT people, move through the world. What they share, what they don't, and with whom. And this silence has made an entire group of people invisible, unknown, and misunderstood. It's a vacuum that gets filled with fear that then leads to hate. But it doesn't have to be that way. Like you who are journalists, my job as a researcher is to uncover truths and share them in a way that helps people understand and get why they matter. Humanizing data, telling stories is one of the most effective ways of making abstract ideas concrete. But uncovering the data is a challenge when people don't feel like sharing. So when you're asking questions next, think about what information you really need to know. Does the way you frame your question give space for lots of different types of answers? Imagine if they were trans and had to answer, or if they were the same-sex partner, but not actually married, or if their family had rejected them. Does it say I'm okay with who you are and who you love? You're safe here. Does your question shut them out or invite them in? Thank you.
Thank you so much for this really eloquent and fabulous overview. We're going to turn now to Jen. You're a veteran health reporter at CNN, and you're a member of the board of directors of the Association of LGBTQ Journalists, and a past national fellow with the Center for Health Journalism. You think a lot about how best to cover our nation's cultural divide on this topic. What suggestions and ideas do you have for reporters who are pursuing this important and unfolding story?
Thank you so much, Michelle, and thank you to Lindsay and Carrie. They've left me with a lot of great story ideas, and I'm sure they've left everyone in our audience with a lot of great story ideas. I was scribbling away during their moving and important talks, so thank you for all of that. What I can do is give you some advice from my own experience in covering the community so that you can turn all of this great information into great stories without falling into some of the pitfalls that I've seen in some of the coverage of the community, because it can be a little bit tricky, but it is important to cover. And I want everyone at the end of this to come away with thinking that, yes, I can cover these stories. And also, I want to say before I begin, thank you so much to USC. As Michelle mentioned, I was a data fellow. And if you haven't applied for one of these fellowships, please do. The fellowship gave me some great stories for CNN. It also gave me the great foundation for a book and for a thesis topic. I graduated with my MFA last year, so their fellowships can lead to a lot more, and I highly recommend the experience. Okay, next. Now, some of you may have already been covering the LGBTQ plus community, so this may be a little bit of a rehash, but I still have something for you too. I just spoke with my association stylebook editor, and he's letting me give you a sneak peek of some of the new terms that you'll see in an LGJ style guide this year. And if your newsroom uses the AP style guide, the terms you will see there will soon reflect this, because my stylebook editor for NLGJ also happens to work for the AP. For those of you who don't regularly cover the community, because there's so much political rhetoric around this topic, there just needs to be a couple of things you think about when it comes to language and framing things that you want to be mindful of. So I've got some trusted source suggestions for you as well, and a few recommendations on what you can do with all this amazing work once you've published it, because who doesn't like awards? So if you, as you heard from Michelle, I wear several hats when it comes to the community and our health. First, wearing my journalist hat, I have three main pieces of advice. Before CNN, I covered this topic in my side hustle as a freelancer for a variety of publications. And I did this work in addition to my day job in local television. I did it because I was passionate about the topic, and I thought our community really needed accurate health information to protect themselves. And frankly, in the job I had as a mainstream media person, the folks there weren't interested in the topics, unfortunately, at the time. And sometimes they were even hostile. I tried to cover why it was that gay men at one point in time couldn't give blood. My news director at that time in the local network said, I'm sorry, you can't cover this story. And I asked why. And she said, quote, gay men are icky and our audience will think that too and turn off the TV. Fortunately now, next, I work at CNN and I no longer have this problem. CNN knows how important it is to cover the community, how important it is to put a face with the data and with the stories, and how important it is that the community gets fair and accurate coverage as well. One bit of advice I can give you if you want to pitch these kind of stories to your editors, there is a big readership for these kind of topics and a powerful readership at that. These stories get a lot of love and some hate on social media, so you will get a good audience for what it is that you're writing about. Second, I always tell my colleagues, it doesn't have to be Pride Month to write about the gay community, and it doesn't have to be a story solely focused on the community to write about gay people. For instance, I was covering a story about how patients had a hard time accessing care during COVID. I reached out to a gay health clinic as well as a regular community health clinic for the story. It wasn't a gay story per se, but representation matters, visibility matters. And again, remember that that big audience on social media, that particular story got a lot of love. Even if you don't cover health regularly, I also highly recommend any big picture stories about the community, sneak in a mention about a health situation. Health is a topic that everyone can relate to. We all need to go to the doctor, and we all know what it would be like if a doctor didn't listen to us and give us the care that we needed. For example, I wrote a story about how retirement got a little bit easier for the LGBTQ community with marriage because we can share each other's Social Security income. But in that story, I also snuck in some information about how difficult it is for people of retirement age who need a nursing home, because as you had just heard, they can't always be gay friendly, and a lot of people have to go back into the closet, and that can be difficult. It was a good opportunity for me to remind people, even in a story that was showing something positive about some of the developments and acceptance of gay people, that the community still does face some huge barriers. Next. Okay, the second piece of advice, you want to develop good sources, good go-to sources who can respond to you quickly to suss out if something doesn't always sound right or can give you a quick perspective on these important topics. Lindsay and Carrie, who are obviously great resources on these topics you've heard from today, definitely follow up with them. I know they will be able to help you. Looking for any good data, the Williams Institute at UCLA's Law School, they are absolutely fantastic and solid, and they cover a lot of LGBTQ topics. They're kind of like Guttmacher if you cover abortion. Williams Institute's really good. From the front lines perspective, Fenway LGBTQ plus Health Clinic in Boston, they've got great clinicians and they stay on top of trends. NMAC, they're great on racial justice and HIV. They can also talk a lot about other health matters too. Last year when I was covering the Mpox vaccine story, how people were saying that there weren't enough vaccines for the community, both of NMAC and Fenway were great on those topics. And NALGAF, they're great on LGBTQ related addiction topics. Pew has lots of good survey data. KFF, as you've seen, has, well, they're good on absolutely everything. So definitely use them. GLMA, the health professionals in advancing LGBTQ plus equality. If you need any doctors or medical professionals, they're really quick to get back and they have access to absolutely everyone. You know, the CDC does have decent data, especially about young people. Good luck on getting a call from them, but again, their data is pretty reliable when they have it. And finally, one resource that's not on this slide, LGBTQ people in your newsroom. Now, you don't want to out anyone, and it's a little bit trickier, but often people who are part of the community want to make sure that the community's coverage is accurate and fair. So I get calls all the time from other people in my organization at CNN asking for me to read scripts, to look at language, to bounce ideas off of. I am always, always happy to help. I want to make sure our organization gets the coverage right. And I'm sure you have someone in your newsroom that would be happy to help. Just ask carefully and don't ask when they're on deadline. Next, the third piece of advice in covering this community is to develop a thick skin. Like with a lot of potentially subject matter, I get a lot of hate mail on this topic, just like I do with vaccines and a few others. I won't share the obscene stuff I've seen or the violent stuff. Here's one I can share. This blogger called me a stenographer for the community, and they called me patient zero of all terms, saying I introduced language that people were now using in the broader national conversation about gender affirming care as medically necessary evidence-based care. That's not something I didn't make up. I didn't invent that. The AMA did. It's nice to be all powerful, but it's not always fun to get some of the nasty things people say in my inbox or online. So just be prepared for that. I would never steer you away from covering this community. It's a really important community to cover. Just prepare your editors for some of the backlash and make sure they give you time to either answer questions or give you time to be by yourself and quiet and not worry about the nasty things people are saying about you, because this work is really important. Next. That leads me to the second hat that I wear. I am the past president and a longtime national elected board member of the Association of LGBTQ Journalists. For those who don't know about us, we're a professional association that offers conventions, mentorships, even a book club. We also have a rapid response task force. You want to avoid hearing from us. We are journalists working behind the scenes to make sure that coverage is fair and accurate. To avoid hearing from us, use our style guide. It's by journalists for journalists. I'm not a member of TJA. They also have a really good style guide about trans issues, also done by journalists for journalists. NLGJA is also, the style guide is also translated into Spanish with the help of NAHJ, so it's really helpful there. And we have awards. So when you write up all this great information, there's a health category that I strongly encourage you to apply for that award. There are several other awards that could apply to this kind of coverage, and you don't have to be a member. But of course, you're always welcome and allies are always welcome. Next. At the Rapid Response Task Force often sees coverage that can be problematic. Some language that you definitely want to steer away from, since it gives the reader the wrong impression that you're biased against the community, are words like homosexual. That's a word that the far right uses. Instead, you just want to use the term LGBTQ plus for inclusivity, to include the whole community. Sometimes I shorthand it as gay on second reference. It just depends on how people identify. Same-sex marriage, you don't want to use that anymore. just say marriage, because same-sex couple in a marriage is a marriage. Sexual preference, that's out too. So please use the term sexual orientation if you can, because it's not a preference. And please, by all means, do not use the term groomer. It's disgusting. It's awful. It's really upsetting. Don't even use so-called groomer. Please, please, please avoid that. Next. Language about our community changes rapidly, in part because people hate us, try to label us. So new for 2024, sorry, in the NLGJA style book, instead of openly gay, because that sounds really strange and scientific, and maybe we should be ashamed of it, just please use the term out for gay and lesbian or trans. You can use the term gay bar. LGBTQ bar is probably a lot to say. And in this case, the colloquial is fine. Most important this year, avoid using the term biological male. I've seen that in copy lately. And since this tends to confuse or oversimplify the differences in sex and gender, or it conflates the two, conservatives have started to call trans girls and trans women biological males. And that invalidates the person's identity. Plus, biological sex, is redundant since sex is inherently biological. So go with how the person identifies, not how opponents of trans rights define, or people who are against the trans community identify them. Use terms like sex assigned at birth, for instance. Next. In summary, when you're covering the community, be thoughtful about it. Mistakes can happen, just fix them fast and be transparent about it. Also think something to keep in mind, sometimes balance, we always try for balance in our stories, but when it comes to the community, balance isn't quite the right metric. Go for the truth. You don't want to quote a politician who's conservative, who hates on the community. You want to quote the doctors about the community. You want to quote the experts about the community. Just like with the January 6th insurrection, you wouldn't ask an insurrectionist for their perspective about what it is they think happened. You want to talk about what the truth was there. Same with the LGBTQ community. Next. Finally, the last hat, and I want to be quick about this, is, I am a lesbian and I am a patient, and I definitely have had some bad experiences at the doctor. I am embarrassed about that. I cover health for a living. I understand this topic really well, but when it happens, it's overwhelming and it's upsetting. So just keep in mind when you ask for people to be a part of the story that, to be sensitive about it, just like you are when you talk to other people. It's hard to talk about it, but I know there are lots of people who would be happy to share their story, and these are really important stories to share. Thanks so much.
Thank you so much, Jen. What a great conversation. And we're about to open it up to all of you. And we have a few questions in the Q&A, and I just want to invite everyone to share more. And I also, before we turn to some of those questions, want to ask all of you for any insights you might have or ideas about either stories that you think are underexplored in this arena, perhaps some that seem very timely in light of everything we've been talking about, or just even stories that you think, let's keep it on the positive side. So yeah, stories that you think are up, there's some great opportunities out there for journalists. I don't know if one of you wants to start.
I'm happy to jump in. Two things came to mind as everybody was talking. And the first is that I think a really important role for journalists in general is to cut through misinformation. And this is certainly an area that is not only laden with misinformation, but that misinformation has become politicized. And I think that we'll continue to see that in the election cycle. And so to be able to cut through the noise, to provide evidence-based factual information about some of these challenges and some of the policies that are being implemented, I think is a really critical role for journalists. And now I don't remember the second one. So I'll let you know if it comes back
If it comes to you as we go around, please chime in. Carrie, did you want to share anything?
No, not related to that. I think Jen will probably, if Lindsay remembers hers, or if Jen wants
I
to
do
say.
remember it.
Good.
Oh, go for it.
Something that I have not seen covered, but I think is really interesting is that for providers who are in these 24 states who want to provide evidence-based best practice medicine for their patients, they're put in a very difficult position between doing what they think is best as a provider based on clinical expertise and wanting to not only do no harm to their patients, but because we know that these interventions can be life-saving for individuals, the people who are denied gender-affirming care are at higher risk for mental health problems, including at risk for increased suicidality. That providers are being told they can't provide this preventive care by the state, but they may know it's in the best interest as a provider. And so they're stuck between a rock and a hard place. And I know it's difficult for providers to become sources and certainly named sources in this area, but I do think that that tension is something that may be worth investigating.
Thank you. And Jen, did you have some suggestions for folks?
Well, one thing that we don't see a lot of coverage of is bisexual health. For some reason, people have ignore the community, and I see that even with the stories that are entered into our competition for coverage for the community. The more people can do to cover people who are bi, I think that would be helpful in terms of stigma and putting a face to some of the challenges that bi folks are experiencing.
And is there anything else in that arena that, just to give us a sense of what sorts of things you're thinking would be different for a bi focus?
I mean, just including a person who's bi within your larger coverage of community healthcare would be good. Sexual health, certainly those kind of conversations, doctors probably don't even think about that as much as they probably should. There's certainly stigma even from the community about bi people. So just talking about that certainly helps for sure.
Okay. Well, I'm going to turn to some of our questions here.
Michelle, just on that note, when we to Jen's on our planning call, I know that that recent JAMA article just came out that actually showed that, I don't know if you saw it, Jen, that bisexual women and lesbian women are they experience mortality at a much higher rate than heterosexual women, 26%. They die sooner. So one idea too, it just came out, I think, last month.
Thank you. We'll try to put that in the chat while we keep talking. So we have a question from, I hope I'm pronouncing the name correctly, Lisi Beveridge, who says, I'm in Mississippi. Healthcare is an issue here for marginalized communities, and reporting on women's health or trans health is nearly impossible since many fear retaliation and we can't use anonymous sources. Any suggestions on how to approach healthcare issues without putting a target on someone's back? Jen, did you want to take a first pass at that, or?
Gosh, that's tricky if you can't use anonymous sources. In some cases, you could certainly talk to people outside of the state, maybe that wouldn't feel repercussions. And certainly some of the LGBTQ clinics could help you there. Sometimes doctors who are part of the community could also talk about their own experience, and they may be braver in that circumstance. And often there are people in the activist community who, regardless of the consequences, will be brave and will speak. It never hurts to ask.
Thank you, Jen. We have a question from Gloria Bozeman, who asks, who says the experience of the LGBTQ plus population sounds familiar to those experienced in the marginalized African-American population. Has there been any particular focus on the intersectionality of race and how that might further impact those members of the LGBTQ plus community?
I'm happy to start. This is an important question, and it's something we think about a lot. And of course, people lead intersectional lives. So there isn't just one LGBTQ experience, but there's the experience of somebody who is Black living in the United States, for whom they moved here when they were younger and English isn't their first language, and they're living in poverty, right? So you have this like dimensional personality, which is why in our questions about discrimination, we didn't specifically ask what this discrimination was based on at first, but wanted to get at the broader experience. So I think number one, this is an important question. Number two, part of what you're asking is a methodological data question. So for our polling at KFF, we ask LGBT identity in all of our questions, in all of our polls. Our polls are nationally representative. So that means that they have really rigorous standards, and it's quite expensive to field. And so the size of the population is usually around 1,000 people, and we'll have enough of an LGBT adult sample to report on that group, but it's harder to break out sort of identities. With the data I presented, we were really fortunate that that was a pretty large survey. We had over 500 LGBT identified adults. And so we were able to give some of those breaks around like age and poverty. And I didn't present most of the race ethnicity data there because I was highlighting the findings where we found statistical differences. And actually, we found that among LGBT people, we didn't see higher rates of discrimination among people of color compared to white people. But we did see some differences that were just a little more difficult to explain for the purposes of the webinar that I'm happy to share if you want to contact me. But it was things like among Black and Hispanic LGBT people, those who experienced discrimination were more likely to say that was due to race ethnicity. So it's complicated, and part of it is a data issue, but it's important. And it's important to acknowledge that the community isn't sort of like one face.
Thank you. Did anybody else want to tackle this intersectionality question? We have another intersectionality question too, but maybe we'll start with this one.
I was just going to bring in Elizabeth, yours comment too, because I think what Lindsay said, and also I think we're getting better at talking about.
Do you want to just read her question just because the rest of the audience can't see it? Or I'm happy to do that too, if that's helpful.
Sure. So she wanted to talk about intersectionality, and could the panelists also talk about needed stories that examine LGBTQ plus people's healthcare experiences with intersections of race, disability, class, languages spoken, citizenship, etc. And I think it's an excellent question as well. And I think just underscores how important it is to actually be able to see how these different intersections disproportionately affect people who are LGBTQ and how they really impact healthcare. So I think it's great that we're talking about it, but I think Elizabeth's point to actually begin to tell stories and hear stories about how these intersections really do concretely impact people's health would be really meaningful.
Both we had two people mentioning disability as another intersectionality, and I don't know if anybody wanted to touch on that and any insights or data that touch on that.
I mean, I don't have a specific data point to share right now, but I think that, again, it just highlights the importance of providing really comprehensive full pictures of individuals, particularly as journalists, when you have the opportunity to do in-depth interviewing with people and really get to know sort of the breadth of their experience in a way that we're not going to be able to find in quantitative data.
We have a question from Samson. Hi there. He writes, I'm a trans reporter finishing a project for The Advocate on the public health impact of hate crimes in LA. He's part of our 2023 USC Data Fellowship. It's great work, but challenging. Any tips for managing mental health while doing this challenging reporting?
I mean, I can say it's really good to take breaks. I know we are under amazing deadline pressure all the time, but it's important to get up and take a walk. It's important to do some self-care while you're managing these tough topics. I also find, through the association, I have lots of fellow journalists I can talk to about it, which I think is helpful because, when you're isolated, you can certainly go into a spiral, thinking negative thoughts about everything. It's so good that you're working on this kind of work. I'm so glad you're doing it. My email's out there, so feel free to reach out to me. And I certainly have good friends in the LA area if you need folks to talk to who can certainly help with that.
Thank you, Jen. And we have a question from Alan Siegler, who asks, as a in the media ecosystem, are we seeing an increase in the share of LGBTQ plus reporters? How important is that representation, and what steps can newsrooms take to make LGBTQ reporters feel welcome?
Oh, great question. I can certainly say, you know, we've seen a lot more members joining. We've actually, I think, quadrupled our membership recently. So I am seeing a good number of LGBTQ people going into the media, which is great. But in order to support folks, we certainly have heard from new journalists talking about going into smaller markets, and sometimes that can be difficult, as you can imagine. So making sure that we have wider networks to be able to talk to each other is really key, for sure. The associations really helped me with that. Sorry to keep talking about that, but that helps. As far as making people feel welcome, I think it's always important to, as a manager, talk about intersectionality and to talk about how we value diversity in our coverage and how we value that within our newsroom as well. I think, you know, emulating that in our conversations, encouraging our direct reports to look for sources that are diverse is really important. And just modeling that good behavior, I think, makes people feel more welcome, for sure.
Thank you, Jen. We have a question from Roy Edroso. I hope I'm pronouncing your name correctly. I appreciate the sources provided and would only ask, if one were seeking really granular federal policy analysis in terms of practical effect, for example, the new 1557 rule and how it would affect the way doctors should change protocols, with whom would you start?
Well, you know, I mean, at KFF, our audience isn't providers, but we do really aim for our policy analysis to be deep and rich, but understandable. So with 1557, we've broken out an analysis, and hopefully that is something that individuals could understand. It may also be the case that major medical associations will provide guidance around 1557. And then similarly, I think with other policies as well.
And we have a comment here that I'll just share, not really a question, but from somebody who's anonymous, who says, as a bisexual nurse working for a faith-based hospital in Florida, the healthcare field, excuse me, frequently ignores the bisexual community and shows a lack of education for our medical providers' cultural humility training. I didn't even know that was the track. I would love to see more articles regarding the intersectionality between providers' implicit biases, the fields they specialize in, and LGBTQ plus patient satisfaction scores. And I think we're close to the end of our program, but we have time for one more question. This is from Mo. Again, I hope I'm pronouncing your name correctly. Meixner. I have another intersectionality question. How are you seeing and expecting LGBTQ plus people affected by the climate crisis after the experience of the pandemic? I'm guessing by the silence that this is not an area of active research, but maybe just something you know, to think about for the future. And I think I see one more question in the chat. A second. So in terms of changing the script and creating more inclusive healthcare settings for LGBTQ patients, what health systems are leading the way, and what role does medical school education play?
Can start. Curriculum plays a huge role. I think we're now, at least in Colorado, we're up to 6 hours of our medical education going towards LGBTQ content, which is really significant, up from, I think it was 2.5 hours. In terms of leading the way, I think there are a lot of great people. I don't know that I feel totally comfortable calling anyone out, but I think it is great, just the breadth of education happening, not just on the coast, but in places like Madison, Wisconsin, and Ann Arbor, Michigan, places that we don't typically consider. They're doing really remarkable work, having an LGBTQ fellowship, actually having pride groups for the medical students. So there's a lot of great work being done, which I think gives us a lot of hope that things will improve, are improving.
Thank you. Well, I want to offer our thanks to Lindsay, Carrie, and Jen, and to the audience for all of their great questions. We'll be emailing you a survey asking for your feedback on today's program and for your ideas and other topics of interest. Please take a moment to complete it. We also urge you to help support these webinars. You can find more information here on how to do that. We'll be archiving this webinar a little later today at centerforhealthjournalism.org. Thanks so much for joining us, and have a wonderful day.